to YouTube.
YouTube also, Shiva. YouTube.
Started, sir.
Okay. Good evening, ladies and gentlemen. I am Dr. NARAYANAN JANAKIRAM. And as you know, Royal Pearl ENT Hospital, group of hospitals, is keen on propagating academics throughout the globe. And in fulfilling this endeavor, we are now posting live surgeries almost every day. Apart from that, to help the postgraduates, I have requested my classmate, I call him the encyclopedia of ENT, Professor Anthony Rajan, who is the head of department of ENT, Madras Medical College, Unit 4. And he has kindly consented to do a series of live programs just for the sake of exam-going PGs. Dr. Anthony is a very well-read person, and his questions are very, very thought-provoking. And he conducts the exam just like the real MS exam, without informing the questions to the candidates. And as you know, it'll be very nice if you can actually answer the questions or you can write down the answers if you do not know, so that it will be helpful for your PG exams. We have today with us a brilliant postgraduate from Madras Medical College, Dr. Obia Prakash. She is doing her third year MS ENT from Unit 4 of Madras Medical College. And she is going to be examined by Professor Anthony. And today's topic is CA maxilla, carcinoma maxilla, which is a short case for you in your MS exams. I am actually at the moment in Uzbekistan. I am coming to you live from, I operate in several countries, as you know. Next month, I'm operating Jordan, then Bolivia, and so many other countries in South America. So this program will be taken over by two of my own people. One is my son, Dr. SATHYANARAYANAN JANAKIRAM, and I consider the second son, Dr. Shiva. And Dr. Shiva is also a postgraduate of Madras Medical College and has been trained by Professor Anthony, one of the most brilliant fellows I have. And of course, these two will be conducting the moderating the program, and Professor Anthony will be conducting the exam. I'm sure this is going to be of great use to all the postgraduates, and this will be on our YouTube channel, Royal Pearl RPH ENT University YouTube channel. So over to you, Professor Anthony. Are you there?
Yeah, I have joined.
Okay, so I'll be leaving now. Yes, I can see the bright face of Professor Anthony. Thank you so much, Professor Anthony. Always you have been there to help the postgraduates. And believe me, this program is now the highest I can say. And people are, when is this next grand rounds? That is the popularity which Professor Anthony has gained. It is simply because of his commitment to academics. Very honest and very sincere professor. And over to you, Professor Anthony.
Hello everyone.
Yes.
Yes. Today we are going to see the CA maxilla. Okay. CA maxilla. Hello. Can we start?
Yes, sir, we can hear you, Professor Anthony. We can hear you.
Yeah. CA maxilla is the topic. The nose case, usually they keep CA maxilla. If you are not from a big hospital, you might get other cases like polyps and things like that. But generally, they keep CA maxilla for the MSPGs, and CA malignancy or benign tumor which resembles malignancy or kept at least as a short case or one of the three cases if it's kept as three cases, right? And most of the time they don't give much importance to the maxilla as they give importance to the cholesteatoma or to that of a CA larynx hypopharynx. With this intro, we'll go to the presentation. I think the person who doing this presentation is already known to us. This is Ovia. She did as a stopgap when it was given to her at the time of last hour. She managed to do the management of cholesteatoma. So, are you ready, Ovia?
Yes, sir. I'll start screen sharing, sir.
Sorry?
Shall I start screen sharing, sir?
Yeah, please start.
Yes.
Before that, let me say hi to Sathya and Siva. Both of them are pillars of this year's grand rounds. And Sathya is the one who is insisting us to do the grand rounds as early as possible. When we have decided this when we were coming back from Avecon in the flight. So thank you, Sathya. Let's start the presentation now. Okay.
Good evening, sir. A 64-year-old male from Krishnagiri district who is a daily wager by occupation belonging to the low socioeconomic class presented with the chief complaints of right-sided nasal obstruction for 1 year, swelling on the right side of the face for 5 months. So history of presenting illness, the patient
What
was
are the cardinal symptoms of nasal diseases?
It would be nasal obstruction, nasal discharge, epistaxis, headache, and loss of smell, sir, anosmia.
Okay. So whenever you talk about a nasal cavity, you should tell positive and negative history of this. Okay. But when you are talking about a nose and pharyngeal sinuses malignancy, there are 5 groups of symptoms. What are all the 5 groups of symptoms?
Nasal symptoms, oral symptoms, orbital symptoms, facial, and neurological symptoms.
What are all the phases of phases of pharyngeal sinus malignancies?
It is called as Robin's phases of CA maxilla. Stage 1 is intractable sinusitis, where you will find only opacification of the sinuses. Stage 2 is dull aching pain, which occurs due to osteitis, underlying osteitis and bony erosion. Stage 3 is deep pain, which occurs when there is a neurological involvement. And stage 4 is local or distant metastasis.
So these are all the 4 phases of the CA maxilla. What is the prognosis of the pharyngeal sinuses malignancies?
In early T1 disease, the prognosis is
generally prognosis of the maxillary or pharyngeal sinuses malignancy in the treating tertiary care hospitals.
50%.
That's very good, bad, or very good.
Sir, it is for bad prognosis, sir.
Bad prognosis. Why?
Because usually the nasal carcinomas are not identified at the early stage, sir. The gap between the presentation, the first symptoms and the identification is around 6 months, sir. So we catch the patients only at the later stage. So the prognosis.
When we are talking about the phases, usually we see the maxillary, the nose and pharyngeal sinuses malignancies at the phase 2 or phase 3 or phase 4. Unless you make diagnosis of phase 1, you will not improve the prognosis of the maxillary malignancies. That is the idea of this presentation. After the advent of an endoscope, after the advent of these CT scans available at all the district headquarters hospitals, the chances for diagnosing the phase 1 malignant diseases is becoming higher and higher. But in spite of that, unless we make these diagnoses of phase 1 or phase 2 diseases, we will not improve the management or the outcome of the paralysis sinuses malignancies. Okay, with this intro and what all things she has said about the phases and the stages, we'll go to the presentation, right?
I'll proceed, sir.
Yes.
History of present-
What are all the presenting symptoms?
nasal obstruction, nasal discharge, sir. Bleeding from the nose, epistaxis, headache, and loss of smell, sir. And
No, what are all the symptoms patient has got?
Patient has got nasal obstruction, nasal discharge, bleeding, and hyposmia, sir. Patient also has history of swelling of the face, sir. Facial
You
symptoms.
understand what is the difference between what you were told before and what you are told now? You are presented with nasal obstruction and facial pain. So the patient has got nasal obstruction, epistaxis, and facial asymmetry now. Okay, right. Then proceed.
The patient was apparently normal one year back and presented with history of.
Change the slide.
Sir,
Change your slide. It's still in the case presentation only.
Sir, I've changed it, sir.
Hello?
Sir, I'm changing it here, sir.
I don't see here. Siva, what's happening?
Sir, 1 minute, sir. I'll check. Sir.
She's sharing the wrong one. Oh. Okay. Okay, you present as it comes, we will change the slides for you.
So history of presenting illness. The patient was apparently normal 1 year back and presented with history of right-sided nasal obstruction for 1 year, which was insidious in onset.
So when was it started?
1 year back, sir.
That is the reason for this advanced disease. Right? Okay. Then.
Progressive in nature, initially partial obstruction, and now it is a complete obstruction for the past 4 months. No aggravating or relieving factors, and nasal obstruction is associated with nasal discharge. So history of nasal discharge on the right side for the past 1 year, which was insidious in onset, intermittent in nature, initially mucoid. Now it is blood stained on and off for the past 4 months. No, not foul smelling, no aggravating or relieving factors.
Whenever you talk about nasal discharge, you should talk also about one important factor, which is post-nasal drip.
Not associated with post-nasal drip.
Usually, all nasal discharge will be associated with the post-nasal drip. Okay, the post-nasal drips, how do you classify post-nasal drips? Purulent or mucopurulent discharges and serous discharges. Serous discharges comes in a variety of diseases, but mucopurulent discharges comes with associated sinusitis. So what are all the effects of postnasal discharge? Forget about this case. What are all the effects of purulent postnasal discharge?
Hello.
Can you hear? Ovia? Hello, Ovia?
Yes, sir. Now I can hear, sir. Yes, sir.
Yeah, what are all the effects?
Hello.
Forget about this case. Okay.
Hello.
Hello. Can you hear me?
Sir, hello. Yes, sir.
See, forget about this case. What are all the effects of postnasal discharge? Hello. So this thing is fine. Sorry, next one.
Hello.
Ovia, can you hear?
Yes, sir.
Yeah. Okay. Tell me, Ovia. See, forget about this patient. When the patient has got a purulent postnasal discharge, what are all the problems what happen to the patient?
Patient will have recurrent cough.
You are going straight to the larynx. See, this the patient has got a small mass, okay, with which obstruct partially obstruct the sinuses, producing sinusitis, postnasal drip. If there is a postnasal drip, what are all things will happen to the patient? So there will be a sinusitis, rhinitis, right? It goes back, what will happen? You get nasopharyngitis and then
sore throat, pharyngeal.
if this patient complains of if patient complains of ear block on the right side, what do you think of?
Eustachian tube pathology, sir.
Sinusitis won't it produce eustachian tube pathology?
Because of the inflammation of the
produce eustachian tube pathology or not?
Yes, sir.
So that is called eustachian catarrh. So once that there is a postnasal drip, it produces eustachian catarrh. Then it produces nasopharyngitis. Then it produces pharyngitis. Then tonsillitis. Then you have a lingual tonsillitis. Then it goes behind, it gets laryngitis. That's the stage you will start getting cough. Then it can go into the aerodigestive tract or it can go into the airway. If it goes inside the airway, it can produce tracheitis, bronchitis, laryngotracheitis, bronchitis, and even it can produce lung abscess. Similarly, the chronic swallowing of pus will produce gastritis, gastroenteritis, and mesenteric adenitis. Which age group mesenteric adenitis is common?
Younger
children. Okay. How will you diagnose mesenteric adenitis? See a palpable mass in the abdomen, which can be moved right angle to the axis of mesenteric attachment. Okay. Then what else you see? So these are all the complications of postnasal drip. Okay, even irritating serious postnasal drip can produce all these problems to an extent. Definitely, it can produce irritating cough. Okay, then okay, continue. Nasal discharge. Then next.
So next slide.
Next slide.
History of epistaxis on the right side of nose for the past 4 months. 4 episodes, moderate amount, which is spontaneous bleed and stops with local pressure. And the last episode was 20 days back, sir.
Okay.
The patient also had history of loss of smell perception, sir.
Loss of smell.
For the smell for the past 4 months. There was history of swelling on the right side of the face
Loss
for the
of
past
smell
5 months.
patient
Sir.
complaints.
Yes, sir. He's not able to smell when he eats food.
Okay. Then
Patient has history of swelling on the right side of the face, which was insidious in onset, progressive to attain the present size, diffuse type of swelling, and the swelling was not associated with pain or any discharging sinuses or skin changes. Patient also has history of watering on the right eye on and off for the past 4 months. Sir.
what are the cause of watering of the eye?
Large mass causing obstruction of the nasolacrimal duct or invasion of the nasolacrimal duct, sir. Or it may be due to proptosis of the eye or involvement of the eye leading to water.
Nasolacrimal duct. What is the other cause?
Sir?
Obstruction can be at the level of the nasolacrimal duct, or it can be at the level of the sac.
Yes, sir.
There can be direct infiltration of the sac, and occupying sac can produce the dacryocystitis. Then second one is exposure keratitis, and exposure of the cornea and conjunctiva. You are producing watering of the eyes. Okay. Then.
Okay.
So watering of the eyes can be because of nasolacrimal duct obstruction or lacrimal sac invasion, or because of the proptosis, a direct infiltration of the tumor into the orbit. Okay. Then.
So there is no history of
previous slide. Don't change the slide. Wait. Okay. Then no previous slide. Okay. Then watering of the eyes. Next slide. Okay, present.
Sir, there is no history of facial heaviness or headache, no history of recurrent sneezing, no history of snoring or mouth breathing.
Okay, you have finished next. What are all the groups of symptoms you should concentrate when you are presenting a nose and paralysis sinuses malignancies?
Nasal symptoms, sir.
Group one is nasal symptoms.
Then I'll consider oral symptoms, orbital symptoms.
Is there any oral symptoms?
Facial.
Second is oral symptoms. Is there any oral symptoms?
No. No, sir, there is no oral symptoms.
Okay. Then third is
orbital symptoms.
Orbital symptoms. What are all the orbital symptoms that the patient has got?
Patient has only watering of eyes, sir.
Okay.
There is no proptosis.
What are the negativities?
There is no proptosis or diplopia. There is no loss of vision or visual disturbances. There is no drooping of eyelids.
Okay, then.
Then facial symptoms, sir. Any facial asymmetry or swelling of the face. Patient has facial symptoms, sir. He has swelling on the right side of the face.
Okay.
And lastly, neurological symptoms, sir.
Trismus. Facial symptoms comes along with trismus.
Okay.
There is no history of trismus.
Okay.
So the facial symptom means it comes outside. The outside can come inside nasal cavity, or to the oral cavity, or to the face, or to the posteriorly into the infratemporal fossa and the pterygopalatine fossa. So infratemporal fossa involvement can produce trismus. Okay. Then.
Okay. Neurological symptoms like loss of pain.
Okay. Right. Loss of
sensation over the palate and alveolar region.
Oral cavities, you should look for ill-fitting dentures. Widening of the alveolar margins. You should look for sensation of the tooth. Whether there is any hypersensitive tooth, whether there is a loosening of tooth. Okay. Whether any boroantral fistula. And then any swelling of the palate. Whether there is any swelling of the palate. These are all the things you should look for when you look for the oral symptoms. Okay. Then neurological symptoms.
Neurological symptoms, any facial pain, sir.
Facial pain is because of
Involvement of maxillary division of trigeminal nerve.
all divisions of trigeminal nerve can get involved. There's a retrograde spread through the maxillary division can go involve the Meckel's scale. So you get a trigeminal neuralgia can involve the ophthalmic, maxillary, and mandibular division. Okay, then
Patient has no history of difficulty in lifting up of neck, no history of fever, loss of weight or loss of appetite.
okay. Then next slide. Okay, then
So there's no ear complaint, sir, and there is no voice change or difficulty in breathing.
okay, next.
So patient is a known hypertensive for the past 10 years and is on regular medication, not on diabetic or not on any other medication. Patient has no history of taking bath in ponds, and no history of any tooth extraction, no history of occupational exposure to wood.
What are all the etiological factors for the disease?
It is exposure to wood, is a softwood and hardwood exposure, and exposure to nickel chromium industries, aflatoxin and chlorotras exposure, and smoking and reverse smoking can also cause CMS.
Oral cavity malignancies. Okay. Alcohol.
Alcohol per se does not have any influence on CA maxilla, but any synergistic primary tumor can be present due to alcohol consumption.
The one good news for the people who indulge in drinking is that CA nose and parathyroiditis will not be the alcohol is not a predisposing factor for these diseases. Okay, so alcohol will not produce this. It can produce some other the second primary, but not directly related to nose and parathyroiditis malignancies. Okay, then where is this disease is common? Which part of the world this disease is common?
Tropical countries.
Why tropical countries? Industrial areas where the industrial toxin is high. No, these areas it is more common compared to that of the other areas. Then
The next slide.
Okay.
Personal history: patient consumes mixed diet, normal sleep and appetite, normal bowel and bladder movement. He's a smoker for 30 years. Smokes 2 BD per day and stopped 2 years back. Consumes alcohol 180 ml per day, once in 2 days for the past 25 years. No significant family history, no similar complaints in the family. Surgical history: no significant surgical history. Treatment history: no significant.
Okay, on examination.
General examination: the patient is conscious, oriented, and afebrile, moderately bitter nourished. There is no pallor, icterus, cyanosis.
Sure. Sure, this patient has got epistaxis. Even 20 days back, he had a moderate epistaxis. You sure there is no pallor?
Yes, sir. There is no pallor.
Okay, then.
No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or fetal edema. Vitals are stable. General examination: serious RS, parabdomen, CNS are normal.
See, listen. Wait. When you are presenting a general surgery case, you present the general examination, vitals, then you present, if you are presenting the, when you are presenting the CVS case, you present CVS first. You present the RS case, you present the RS first. If you present general surgery case, you describe the swelling first. Similarly, when you present the ENT case, you present the ENT first. The systemic examination will come later. ENT is the system of your interest. So you got to present the systemic examination of you got to present the ENT examination first. Then only your CVS or should come in the examination. Okay, right, then present examination.
Nose. Examination of the nose, external nose. The contour is found to be altered. The root and ridge is normal. The dorsum, there is fullness present on the right side and left side is normal. Supratip and tip is found to be normal. Nasomaxillary and nasolabial groove was found to be obliterated on the right side and left side it is normal. Ala fullness is present on the right side and left side it is normal. On the vestibular region, the mass is visualized on occupying the vestibular region on the right side and left side it is normal. So next slide.
Next slide.
On tip raising test on the right nasal cavity, a pink friable mass with irregular surface seen on the right nasal cavity extending anteriorly up to the vestibular region, completely occupying the region. On probing, the mass is insensitive to touch, firm in consistency and bleeds on touch. At the vestibular region, the mass is found to be free all around, so no attachment was found at the vestibular region. On anterior rhinoscopic examination of the left nasal cavity, the septum was found to be deviated to the left side. There is normal inferior turbinate. A nasal mucosa was found to be normal.
Why you couldn't go inside and see? Why did you probe deep?
So because the patient had history of epistaxis, sir. So
what? This is not JNA. Malignancy bleeds, it stops. You have a whole nasal cavity filled with mud. You give pressure, it will stop. Which side you are interested in seeing? Why it is important?
the extent of the tumor to know whether the tumor has posterior extension into the choana.
No, not that. See, the attachment, which part is attached is important. There may be a nasal cavity mass, it can be a maxillary sinus mass or an ethmoidal mass. Very, very unlikely an ethmoidal mass because ethmoidal mass involves orbit first before it comes up to the nasal tip. So it can be a nasal cavity mass or a maxillary sinus mass coming inside the nasal cavity. What do you think this mass is of?
So since there is swelling of the face and all, I think it is from the maxillary sinus extending into the nasal cavity.
Then there is the swelling of the dorsum also on the right side. Ala also. Isn't it? How do you know it's not from the nasal septum?
So at the vestibule, it is found to be free from the septum, so it is not attached to the septum.
At the vestibule is fine, deep inside. You should see whether this mass is attached to the nasal septum or not. Okay, you got to probe inside it to see it's attached to the nasal septum or not. Okay, then lateral wall understandable, but not on the nasal septum. Okay, next is posterior rhinoscopy.
Posterior rhinoscopy, the posterior end of septum was found to be normal. The posterior end of turbinates were normal. Eustachian tube orifice was normal, and the fossa of Rosenmuller was free.
Wait. Previous slide. What about the choana?
Choana was free, sir. There was no mass extending into the choana.
You couldn't see the mass through the choana?
No, sir.
What all structures seen in postnatal examination?
I would see the posterior end of the septum, posterior end of inferior turbinate and the middle turbinate, and eustachian tube orifice, fossa of Rosenmuller, and torus tubaris. I would see if adenoids is present, I would be able to see the adenoids.
What forms the roof of the nasopharynx?
The skull, base of skull forms.
Particular. Base is peanut, base is occiput. Okay. Posterior wall. C1, C2, cervical vertebra over which like the paraspinous muscle and the posterior wall of the posterior pharyngeal wall. Okay, what is sinus of Margagni?
It is the space between the base of skull and the superior constrictor muscle.
Which is lined by? What are the structure passing through sinus of Margagni?
Eustachian tube orifice and
you should read. It's not only nose, it's also nasopharynx. Okay, so you through the postnasal examination, you got to see, pharyngeal basilar fascia and buccopharyngeal fascia. So medially pharyngeal basilar fascia, laterally the buccopharyngeal fascia, ascending pharyngeal artery, tensor tympani muscle, and the nerve to tensor tympani. So these are all the structures coming through the sinus of Margagni. Okay, fine. So you got to see the tumor through that. Have you anywhere you see the tumor is covered by slough?
no.
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 Okay, right. Proceed.
So next slide, sir.
Next slide. Okay.
So airway patency test, cottonwool test, there is reduced movement on the right side. Cold spatula test, there is reduced fogging on the right side. And cotton test, there was no improvement.
It's all not important.
Examination of the smell, the patient says there was a reduced perception of smell on the right side on comparison with the left side.
Did the patient tell you?
Yes, sir.
Did you find out or did the patient tell you? He told patient complaints of loss of smell. When one nostril is free out, the patient will complain of loss of smell.
Reduced smell perception.
How? One nose is normal. Okay, how did you check the smell?
After blindfolding the patient and closing one nostril, I would give some familiar non-irritant substances like coffee powder, sir. I gave coffee powder to the patient and asked him to smell it, sir.
Okay, all right. What is UPSIT?
UPSIT is University of Pennsylvania smell identification test, sir. It is
University of Pennsylvania smell identification test. Okay. If the tumor is covered by slough, that indirectly it tells you this tumor, this is the malignant tumor. You have an ulcer which is covered by slough. So ulcerating slough-covered tumors are all friable tumors are usually malignant. Okay, right. No paranasal sinus tenderness. Patient complains of tenderness. Patient complains of pain. But how come there won't be a paranasal sinus tenderness? Where did you check for tenderness?
Sir, I was not able to check it on the right side, sir, except the right maxillary sinuses. All other sinuses, there was no tenderness, sir. Right side, he had swelling, so I did not check it on the right side.
Why you didn't check? That's why you should have checked. What is the cause for tenderness in the case of a CA maxilla?
It could be
What
either.
is that you should, when you have an anterior wall involvement, if you have a pain on the sinus tenderness, what does that mean?
There is underlying osteitis with bone erosion.
Underlying?
Bony erosion, sir. Anterior bony erosion.
Bony erosion will not produce tenderness. It's periosteitis. Okay, definitely there should have been a periosteitis. What importance is that?
The patient is progressing to the stage 2.
Sorry?
The patient is progressing, sir. So
when the patient has got periosteitis, you got to elevate the flap only with the skin and soft tissue. You cannot add the periosteum to that. If there's a bone is intact, there is no periosteitis, then you can retain periosteum. Okay, right then. Next slide.
So coming to the examination of swelling, on inspection, there is a diffuse swelling on the right side of the face in the cheek region, approximately 4 cross 3 centimeters, ill-defined margin, smooth surface, and the skin over the swelling should appear normal. The extent of the swelling was superiorly 0.5 centimeter from the intraorbital region, inferiorly about 1 centimeter from the upper lip. Medially, it is continuous to the lateral wall of the nose, and laterally it was about 5 centimeters from the trachea. On palpation, the infected.
What area is that called?
The canine fossa.
What is the canine fossa?
Superiorly, it is the intraorbital foramen. Inferiorly, it is the alveolar ridge. Medially, it is the piriform apices, the lateral wall of the nose. Laterally, it is canine eminence.
Okay. Then.
On palpation, the inspective findings were confirmed that there was no warmth or tenderness. The swelling was hard in consistency, and the swelling, skin over the swelling was pinchable. Trans-elimination of
what is different from when you, if you describe on palpation, how will you describe? You have confirmed something. How do you describe that in words? If you selling the right side of the face at the region of a canine fossa. Then next line is
with no skin in
next. What is that next line you have told?
No warmth or tenderness.
Diffuse swelling on the right side of the face and the cheek region, approximately 4 to 5 centimeters. Next,
with ill-defined margin.
When you palpate, what is that? What is that will become? When you palpate, don't you know where it is? Till what level it is there? This 0.5 centimeters. Will you see or not?
Yes, sir.
Exactly, you will see, right? On inspection, you can't see the palpation. What is that is called? The margins will become edges. There will be a clear edges. You can't confirm with this. You are seeing, so you don't know where it goes to. On palpation, you know exactly whether orbit is involved or not. Why it is important?
For to plan the surgery, sir, whether
infraorbital margin is involved or not. Then inside the eye, whether there is any tumor is there. That you got to palpate and tell, right? Then where else you will palpate?
Palatal region, sir. Whether
palatal region. What do you look for?
Any gingivobuccal fullness over the gingivobuccal region.
You will palpate gingivobuccal area to see the lower extent, then medial extent, then posterior extent. Why it is important?
Whether
posterior
to do partial.
Why it is important?
For orbital accentration, whether to include orbit into
the posterior extent of the gingivobuccal sulcus. Why it is important? Clinically, you will assess whether the pterygoid plates are involved or not. When you palpate, the tumor goes beyond the third molar, you will think that it is going to the pterygoid wedge, pterygoid bones. Okay, so you got to expect whether the pterygoid involvement is there or not. Similarly, when you palpate on the palate, you look for eggshell crackling. Okay, where did you palpate in the oral cavity?
On the gingivobuccal areas.
Dentition, what did you palpate? Gums, what did you palpate?
Any
you got to shake the tooth and see whether the tooth is shaking. You got to tap and see whether there is any hypersensitivity. What is the nerve supply of upper jaw?
It is posterior-superior alveolar nerve posteriorly, and in the front it is anterosuperior and anterosuperior alveolar nerve.
It comes through what?
From the
posterior superior alveolar nerve comes through what?
It originates before the before the nerve enters the intraorbital foramen.
Oh, intraorbital foramen. Posterior superior dental nerve comes through a posterior superior dental foramen along with the posterior superior dental artery, which is the branch of third part of the internal maxillary artery in the pterygopalatine fossa. Okay, anterior superior dental nerve comes through the incisive canal. Okay, then these are all the things you should palpate, and you should look for sensation, look for widening. You asked all these things, you asked history, but when you examine, you should examine all these structures. Then you should examine orbit. Okay, next slide. How will you check transillumination?
Using a torchlight and then from one side of the mask in a dark room to the other side.
No. Find out how will you check it. Next slide.
Cranial nerve examination or
Orbital examination. Okay, cranial examination.
Olfactory nerve, the patient says there is reduced perception of smell on the right side on comparison to the left. Optic nerve, visual acuity and color vision was normal. Oculomotor, extraocular movements were normal, and trochlear nerve, extraocular movements were normal. Abdominal, corneal reflex was found to be intact. The sensation over the cheek region and face was found to be intact, and muscles of mastication was intact. Abducens nerve, extraocular movements were found to be normal. Facial nerve, the muscles of facial expression was normal, and the taste sensation from the anterior two-third of the tongue was found to be normal. Vestibulocochlear nerve, hearing and balance was found to be normal. Glossopharyngeal and vagus, laryngeal functions was found to be normal. There is no accessory spinal shrugging of.
Okay, all right.
Glossopharyngeal
nerve will show laryngeal functions, is it?
Gag reflexor and.
What is the other sensation from the glossopharyngeal nerve?
Posterior one-third of the tongue, posterior one-third of the tongue taste sensation from the posterior one-third.
How will you check posterior one-third of tongue taste?
Electrogustometry.
How did you check the anterior two-third of the tongue taste?
I would use a solution of either sugar or salt and place it in the tip of the tongue after rinsing the mouth, sir. And without taking into the inside, the tongue is pulled out and the solution is placed in the tip. And the patient is told to dorsum of the tongue.
Dorsum of the tongue. Okay. Why you should hold it in your hand?
Because when he takes it inside, the palatal. It will be spread all along the palatal.
So when the patient swallows, the palate taste buds will get stimulated. So you got to wipe the tongue. You got to ask the patient to pull out the tongue, hold it with your hand, wipe the tongue on top, and take the solution and keep it there. You can't take the crystals, but take the solution. What are all the sensations you will check?
Sour, sweet, bitter.
Then sour. Where will you see the taste sweet buds more?
And the tip of the tongue, sir.
Bitter?
Bitter would be in the dorsal.
Whole place is dorsal. Posterior part of the tongue. Okay. Right then.
Hypoglossal nerve, the movements of the tongue was found to be normal.
Vagus, how will you check?
Sir?
Vagus, how will you check? Vagus now, how will you check?
I would do gag reflex also, sir.
Gag is for the ninth now. Then. Indirect laryngoscopy. Vagus indirect laryngoscopy, laryngeal movements. Okay, what is the Ritzelberger sign?
Loss of sensation over the posterior part of pinna, sir.
Pinna?
And the posterior part of external auditory canal, sir.
Due to?
Due to involvement of the facial nerve, sir.
In the case of an acoustic neuroma, excessive vagus sign is because of the involvement of the vagus. Okay. Then now we check hypoglossal nerve.
Gag reflex and gag reflex.
What is the Arnold's nerve?
Vagus nerve, sir. Nine.
What is the other name of Arnold's nerve?
Alderman's nerve.
Okay. Next slide.
The examination of eye, vision on both sides is found to be more than 3/60. Extraocular movement was full range and there was no restriction of movement. Corneal reflex was present. Roplast test was negative and there was no proptosis. Examination of the neck, external contour was found to be normal. Laryngeal cavity is present. Trachea is midline. Airway is adequate. There is no palpable lymph nodes and no other mass palpable.
Did you ask the patient to look up and see?
Yes.
Why?
For the involvement of retropharyngeal nodes, the patient will complain of pain when he.
Where is that? You are not told. You are not told that. What is the first trachea nodes?
It is the lateral retropharyngeal group of
Name of the node.
Ruvier.
Node of Ruvier. Okay. Then where is the secondary gland nodes?
It is level 2A, sir. 2A group.
Oh, where else can be a first gland nodes?
It can be in the submandibular nodes.
When it will be a submandibular area?
When it involves the skin of the cheek, or when it extends into the oral cavity, or
facial muscle, anterior extension outside bone. Even an periosteitis can produce submandibular node. Then
when there is a complete maxillary sinus obstruction by the tumor due to retrograde.
Maxillary ostium obstruction. There will be a retrograde permeation for the submandibular node. All the maxillary sinus lymph nodes goes around the ostium to the lateral node of Ruvier in the nasopharynx. Right. So when the ostium is obstructed completely, it can't go in the forward direction. So retrograde permeation to the submandibular nodes. Okay, right. So did you palpate submandibular node?
Yes, sir.
Right. Then next slide.
The examination of the oral cavity, poor oral hygiene was noted. Gingivoalveolar surface was normal. There is no bulge. There is no discharge or widening of the alveolar ridges. All of the findings are normal. Oropharyngeal
The first thing you should have told after nose is oropharyngeal examination. Or if you want to tell something positive, you tell facial examination, then oropharyngeal examination, then orbital examination, then the cranial nerve. Okay, not like this. Then.
Okay. Oropharyngeal examination is normal. Indirect laryngoscopy is normal. Ear, preauricular, postauricular region was normal. External auditory canal was normal. And tympanic membrane showed bilateral grade 1 retraction of pars tensa. And hearing and vestibular function was normal.
Okay. Diagnosis.
So my provisional diagnosis is right-sided sinonasal mass, which could probably malignant growth from the right maxillary sinus.
Okay. What is the 8th American ASC classification for CA sinonasal mass?
T1, when there is the tumor is limited to the maxillary sinus without any.
That is the staging for, TNM for maxillary sinus.
Okay.
What is the TNM for nose?
The tumor is limited to the nasal cavity. T1, sir. T2.
Oh, is it the same?
No, sir. It will.
CA maxilla and CA nose is the same?
No, sir.
Oh, what's your diagnosis then?
Maxillary sinus.
The right maxillary sinus. Why you say right maxillary sinus?
Because of the swelling of the anterolateral wall of the maxillary region.
Sorry?
Because there is a swelling in the anterolateral wall of the maxillary region.
Okay. So a tumor arising from the maxilla spread on all directions. Okay. Easiest direction is nasal cavity. Next easiest direction is orbit. Is there orbit involved?
No proptosis. No.
Such a huge nasal cavity mass, there is no orbital involvement. Is there a oral cavity involvement?
No.
There is no oral cavity involvement. And if there's an anterior wall involvement around. But the anterior wall involvement is also on the anterior wall of the dorsum of the nose. So which can be more common this thing? The CA maxilla produces expansion. It spreads in all directions. It can't come to the tip of the nose or dorsum of the nose, ala of the nose, without involving orbit absolutely. Okay, a tumor which involves the nasolacrimal duct or lacrimal sac, a tumor which involves the anterior wall of maxilla, tumor involves the completely nasal cavity without involving orbit and orbit, infratemporal fossa, even it's not seen on the posterior nasal wall, postnasal examination. You imagine a tumor arising from the lateral wall of the nasal cavity. So it comes inside the nasal cavity, completely filling up the nasal cavity, pushing the septum to the opposite side. At the same time, it goes inside that maxillary sinus. When it goes inside maxillary sinus, it involves the nasolacrimal duct. It comes to the anterior end. It's there on the nose. Similarly, it comes anteriorly. It involves the anterior wall of maxilla, which is common. Which is the lateral. Clinically, it is a lateral wall of maxillary tumor. I mean, lateral wall of nasal cavity tumor, or medial wall of maxillary sinus tumor. A tumor arising from the medial wall of the maxillary sinus. How will you confirm?
I will do radiological examination.
So, what is the? Would you like to rephrase it?
Right sinonasal mass, query malignant growth from the lateral wall of the nose.
Okay, then. Yeah, tell me. You want to correct your diagnosis? Malignant growth, nasal cavity extending to the maxilla and to the anterior nasal wall and the anterior wall of anteriorly into the dorsum of the nose. So what is the TNM? So right nasal cavity mass extending to the maxilla, extension into the anterior wall. What's your diagnosis?
T4.
What's T?
T4.
Still it's T3.
But
anterior wall is T3 only. Okay. So it's most probably it's a lateral nasal wall growth. Doesn't look like a CA maxilla per se, because CA maxilla means which part is more common?
inferior and anterior.
Sorry?
Inferior and anterior wall.
Inferior wall. So inferior means first where it will spread, anterior wall or to the oral cavity?
Oral cavity.
Absolutely common is oral cavity. Okay. So without palatal swelling, gingival involvement, nothing, it's very, very unlikely. So most commonly it is from the lateral wall of the maxilla growth. Okay. So how will you proceed?
I would like to take a biopsy of the mass, sir.
Want to take biopsy straight away. You don't even made a diagnosis of maxillary sinus. So you can't call it malignant growth. Why do you think it is you can't call it malignant growth? You got to commit whether it's a benign growth or a malignant growth. A tumor which is filling the entire length of the nasal cavity, involving infiltrating nasolacrimal duct, friable, pinkish, readily bleeds untouched. Usually is malignant growth. So malignant growth, lateral nasal wall. What else is the differential diagnosis?
It would be an inverted papilloma, sir.
Inverted papilloma, but this is the inverted papilloma is a papilliferous growth. Doesn't bleed untouched. It's not friable. Very, very unlikely this can be an inverted papilloma. Occurs at the old age. There is no previous history of surgery. And then patient also get the anterior nasal wall swelling. Very, very unlikely. Then what else? Epistaxis, nasal obstruction, nasal discharge. Granular mass. Rhinosporiosis. Okay, so rhinosporiosis is, how do you describe rhinosporiosis clinically?
It is a granular leafy mass which is arranged in
granular
leafy or papillum
sheath-like or leaf-like masses. Okay, usually it is reddish in color, granular. Then
the undersurface will have whitish specules due to
the surface will have whitish specks, particularly the unexposed undersurface will have white studs. Then
it will be attached to the bony prominences, like the nasal septum spur.
Usually attached to the septum over the bony spur. Then
and upon probing, the mass is insensitive to touch and readily bleeds on touch.
Okay, then how do you classify rhinosporiosis?
Benign rhinosporiosis and malignant rhinosporiosis.
Classify as nasal,
nasopharyngeal.
Nasopharyngeal. The third one is bizarre. Anywhere else is called bizarre. Okay. What is the organism which produces rhinosporiosis?
Rhinosporidium seaberry.
Rhinosporiosis seaberry or otherwise called Rhinosporiosis kenyali. Okay. What is the organism which produces the malignant rhinosporiosis?
Rhinosporidium multilocular.
Rhinosporiosis multilocular. Okay, right. Then what other tumors can occur in the nose? What is the commonest malignant tumor of the nose?
Squamous cell carcinoma.
Squamous cell carcinoma. What other tumors can occur in the nasal cavity?
Adenocarcinoma, adenostic.
Okay.
Malignant melanoma.
Very rare.
Mucous. Chondro.
Adenocarcinoma, adenocystic carcinoma, mucoepidermal carcinoma, small cell tumors. Then other common tumor comes from rufus.
Esthesia neuroblastoma.
Esthesia neuroblastoma. Then soft tissue tumors like
rhabdomyosarcoma.
Rhabdomyosarcomas. Okay, other types of sarcomas, chondrosarcomas, osteosarcomas. Okay, so all these things are all different tumors. Malignant tumors can come from the nasal cavity. Okay, how will you investigate the patient? Before biopsy, what will you do? Before biopsy, what will you do?
Radiological.
You will image the tumors. So what imaging you will do?
Screening X-rays can be done first.
X-rays. Okay. What X-rays will take?
Waters view, Calvil's view, lateral view, and skull base view would be taken.
What is skull base view?
Skull base view, submento vertical.
Submento vertical is skull base view. What do you look for in the skull base view?
I look for triple line of Beckley, sir.
What are all the triple lines of Beckley?
S-shaped posterior wall of maxilla, C-shaped posterolateral wall of the orbit, and curvilinear anterior middle cranial fossa.
So you have 3 lines. Okay. One line is a C-shaped lateral wall of maxilla. Sorry, C-shaped lateral wall of the orbit. Then S-shaped one minute. S-shaped posterolateral wall of the maxillary sinus, and then
the greater wing of sphenoid or the
greater wing of sphenoid. Okay, so all these things put together will meet in one place. Whenever there is a tumor in the paranasal sinuses, it will distort these lines. Okay, then why do you want to take the lateral view?
For the pterygoid involvement, sir.
Anterior and posterior expansion is best seen in the what other sinus is seen best in the lateral view? Sphenoid sinus. Okay. Why do you take calval view? Similarly, anterior and posterior wall of frontal sinus will be seen best in the lateral view. Okay. Why do you take calval view?
For the frontal sinus, sir.
Frontal and ethmoidal sinus.
Ethmoid.
Okay, right. What other investigations do you do? Now you don't take all these X-rays. What do you do?
And the CCT, sir. Contrast enhanced CT of the
contrast enhanced CT. Why you want to take CT scan?
To know
what are the advantages of CT scan?
It'll give the extent of the tumor and bony involvement, skull base involvement, or pterygoid extension.
No. What I am asking is, what are all the advantages of CT scan over MRI?
It will delineate the bony structures better, and bony erosions would be identified better in CT scans.
See the marks, you see the erosions, you see extension, then easily available, easy to do, not very cumbersome. It can be done for the people who are claustrophobic and anxious patients. Okay, these are all the advantages of MRI. Then you can see the MRI will delineate cartilage and bone better. Why you want to delineate cartilage and bone?
For the invasion.
Whenever you see a tumor, the tumor tends to contain its tissue of origin. For a chondrosarcoma or a osteosarcoma, the cartilage or bone will be inside the tumor, which can be picked up well with the CT scan compared with that of MRI. Okay. Then skull base erosion into the posterolateral wall, erosion into the infratemporal fossa, cheek erosions, everything can be involved. Okay, this patient doesn't have big swelling in the oral cavity. Okay, what is the use of MRI in this patient?
For skull base extension, sir. Intracranial extension.
Intracranial extension is how do you differentiate? The brain dura differentiation is better with that of the contrast enhanced MRI compared with that of the other gas. Then retained secretion. Retained secretions, how will you differentiate retained secretions in the CT scan?
The Hounsfield unit.
Hounsfield unit, but the Hounsfield unit of thick tenacious secretions will be very close to that of the edema. So both the things will be about 40 to 70 ounce fill units. If it is 10 ounce fill unit, 20 ounce fill units, you know it's fluid. If it is 80, it is more than 80, you can say it is soft tissue. But in between, it is very difficult to 40 to 70 is very difficult to delineate. The retained secretion delineation from that of the tumor is very difficult with the CT scan alone. Better thing is an MRI. Okay. Then marrow infiltration. The only bone in the parenchymal which contain appreciable amount of marrow is palate. Okay, palate. The marrow invasion is the involvement of the palate. Involvement of the palate, particularly the cases like this, can be better delineated with the MRI compared to that of the CT scan. So to say there is no marrow involvement or there is no bone involvement is better with this MRI. Okay. Then what other investigations you can do?
PET CT, sir.
PET CT. What is the? Is it really useful in this patient?
To rule out metastasis, we can take PET CT. And
PET CT is useful only in metastasis and the recurrences, not in the primary assessment. Why? There's a glucose uptake is increased in both inflammation as well as the tumor. So you cannot differentiate an inflammatory cells from the tumor in the case of a PET scan. So that's not very useful in any way in the nose and parallel sinuses. But to pick up secondaries for the whole body screening, this is the better tool, PET CT. Okay. Then I am not going to discuss about the genomes of CA maxilla because it is too theoretical and it is too difficult to remember. So I advise all of you to read that. Okay, right. Then how will you take biopsy? What's the principle of taking biopsy? Ovi, have you become tired?
No.
Then why your voice has become so low now?
Okay. Melon
The
seed
principle of taking biopsy.
melon seed size biopsies should be taken.
That is different. That is in the nasopharynx, fossa of Rosenberg. So biopsy is you should not cross the surgical barrier fields. Like you should not do a calvolus and take a biopsy, or you should not do a you should not break any normal barrier and take biopsy. So in this case, it's available in the nasal cavity, so you can take it from the nasal cavity itself. If it is confirmed inside the maxillary sinus alone, a suspected tumor, a middle meatal antrostomy should be the best option to do it. We don't do a pre-lacrimal approach, or we don't do the other approaches like modified Denkers like that, because if it's a malignancy, you are breaking the barriers. Okay, like then what do you think this biopsy report will be?
It will be squamous cell carcinoma, sir.
Squamous cell carcinoma. How will you manage squamous cell carcinoma? Patient.
Surgery is the management of choice for
Surgery is the management choice of most of the nose and paranasal sinuses tumors. Okay, what surgery you will do?
I would do a total maxillectomy for this.
If it's the lateral wall of the nose tumor, what surgery you will do?
I will do medial maxillectomy, sir.
What are the indications for medial maxillectomy?
Benign and low-grade tumors. Benign tumor of the nose and low-grade adenocytic carcinoma. No, sir.
Will you remove the anterior wall of maxilla in medial maxillectomy? So
no, sir.
CT scan will tell you whether inside the maxillary sinus tumor is involved or not. If the inside the maxillary sinus, only the medial part is involved. The orbital plate, then your lateral nasal wall, posterior wall of maxilla, everything is free. There's only small amount of retained secretion. It's not involved with tumor. Then you can plan doing a medial maxillectomy. But for this case, once there is a tumor protruding outside the nose, it's very, very unlikely. How will you do? medial maxillary? What are all the parts you will remove?
I will remove the inferior turbinate, medial wall of the maxilla, and the anterolateral wall of the maxilla, medial and part of the inferior wall of the orbit, sir. With the part of
inferior wall of orbit.
A part of a medial wall.
Okay. When you remove the lamina propria, what are all the blood vessels you will see?
Anterior and posterior.
What is the rule of 6? What is the rule of 6? From the lacrimal crest, 24 millimeter is your anterethmal artery. From the anterethmal artery, 12 millimeter is your posterethmal artery. From the posterethmal artery, 6 millimeter is your
optic
nerve. That is called rule of 6. Okay. What incision you will put?
Modified Nodes incision, sir. Nodes lateral rhinotomy.
Nodes lateral and what are the modifications?
It could be with supraciliary extension or subciliary extension, Lynch extension.
Lynch extension, subciliary extension, or lateral extension. Okay. What is the H incision in the Moose incision?
Up to the medial 1/3 of the eye, sir, extending up to the medial 1/3 of the eye.
H incision.
H.
Don't see the open incisions for anterior fossa resection, right? Craniofacial resection you didn't see.
I saw, sir, up to extending up to the head, sir, superiorly it is.
You make a incision, you make both sides, you make incision and connect it in midline. Bilateral lateral rhinotomy incision and connect it in midline. Then you do a bicoronal flap, usually used for craniofacial resection of the olfactory neuroblastoma or tumors extending into the skull base. Okay. Then what are all the other surgeries you? If it involves the maxillary, it completely fills the maxillary sinus. What surgery you do?
Maxillectomy, sir.
What maxillectomy?
Total maxillectomy.
So how will you do total maxillectomy?
I would put a Weber Ferguson incision with subciliary and palatal split, sir. With palatal incision. I'll elevate the flap and expose the bone, sir. Expose the bone laterally up to the zygomatic process. And osteotomies are done. Palatal incision is put, sir. Sublabial incision up to the maxillary tuberosity, and it is extended midline in the junction of hard palate and soft palate to the midline. And just paramedian to the midline, the incision is extended up to the front, till the front, and the flaps are elevated.
Till the medial lateral incisor junction. Okay.
Okay.
Then what will you do?
The cheek flap is elevated, sir.
Lip splitting, cheek flap is elevated. Then
I will make osteotomy, sir, at the frontal process of maxilla, and I will elevate the periosteum from the orbital floor. I will elevate the periosteum to see the inferior orbital fissure. Through the inferior orbital fissure, I will insert a curved artery to identify the pterygomaxillary fissure. Through that, using a giggly saw, I would take out the giggly saw and
why?
For
nowadays we make osteotomy with the electric osteotomes. If I ask you how will you do with the giggly saw, it's right. Otherwise, you use the electric saw to disarticulate maxilla from the zygoma. Then
palatal osteotomy is made in the paramedian.
How will you use giggly saw for the palatal osteotomy?
The curved arteries pass along the floor of the nasal cavity. Through the hard palate soft palate junction, it is taken into the oral cavity. From there, the end of a giggly saw is taken and it is used to cut.
So that loop is taken from the oral cavity to the nasal cavity at the hard palate soft palate junction and then cut. Okay. Then what else you do? What are all the muscles you will disarticulate?
Masseter muscle, sir, at the third maxillary tuberosity level, third molar tooth, I disarticulate masseter muscle and pterygoid muscles.
Okay. Then?
If the pterygoids are not involved, then I would detach the posterior wall of maxilla from the pterygoids using a curved osteotope. And I'll mobilize the maxilla and deliver it out.
Okay. Once you deliver the maxilla, you get the bleeding. Why?
The bleeding can be either due to internal maxillary artery, sir, or due to pterygoid venous plexus.
Okay. If it's an internal maxillary artery, what will you do?
I can ligate or cauterize. I'll try packing, sir, hot saline.
Why don't you cauterize straight away?
It will retract inside the internal maxillary artery. It will usually retract inside and it will the bleeding will settle. Two
things. One is, if you are going to reconstruct it, you need the artery. Or if you preserve the artery's blood supply, most of the other structures are all supplied by the internal maxillary artery in the nose and paranasal sinuses. Okay. So you are retaining the blood supply. If you are retaining the blood supply, then the patient will, the radiotherapy will be effective. Okay, or if you want to give a intra-arterial chemotherapy, that can be done. So you don't ligate generally internal maxillary artery. Okay, then at any level, some people will ligate the first part of the internal maxillary artery. That you should not do if you are planning to reconstruct. Okay, then what else you do?
I can pack saline, warm, hot saline packing in the cavities, sir.
For what?
It will release tissue. It will break the blood clots and release tissue thromboplastin, sir, which will cause
RBCs. It releases tissue thromboplastin. Where will be the bleeding comes from?
Pterygoid plexus of veins.
Pterygoid plexus of veins. So pterygoid plexus of veins moves it. You pack it with the warm saline, it will stop. Okay, because of release of tissue thromboplastin, it will go for contraction and it will stop. Okay, then what will you do?
If there is no residual tumor and if we are sure of no residual,
you remove beautifully the maxilla in toto. Then what will you do?
Then I can reconstruct. I would reconstruct the cavity with a split skin graft or a muscle graft, sir.
Muscle graft. What muscle graft?
Latissimus dorsi or
Latissimus dorsi, only muscle graft?
No, sir. Pectoralis major.
Pec major. Pec major will not come there.
Radial forearm flap or.
You have to reconstruct two things.
Both.
One is palate. Second one is the soft tissue. Soft tissue is reconstructed with the rectus abdominis flap. The bones should be reconstructed with the radial forearm flap or can deal with the iliac crest flap. Okay. Or you got to reconstruct the orbital wall. That can be done with the spinal scapula along with the latissimus dorsi and the serratus anterior with the thoracodorsal vessels. That can be used for a free graft. You got to take that and do the arterial anastomosis. And then if it's a radial forearm, you can make the holes and put a titanium sockets so that you can fix the dentition after that. So soft tissue is filled with the free graft of muscle pedicle vascularized graft, and then bone is from the iliac crest or is from the radial forearm. That's also a vascular flap. Okay, so you got to find two arteries and anastomos. You don't have the microvascular anastomosis technique available. Then what will you do?
I will use an operator, the surgical operator, to close
How many
the cavity.
operators are there?
Surgical or immediate operator, a intermediate operator, and a permanent operator.
What is the use of immediate operator?
Immediate operator will help in hemostasis by better packing, sir, and it helps in speech.
How will you pack the cavity?
Postnasal and anterior
cavity.
Cavity I pack with with the gata pacha, sir, which is
otherwise called dental mold. You take the mold, put it in hot water, make it soft, pack the cavity. Contracture. Then you put the temporary operator. What is the advantage of temporary operator? One is you can keep the pack. Second is
it will help in early feeding and speech, better speech for the patient.
Patient can take food immediately. Patient can speak better immediately because that the nasal twang will not be there. There won't be a huge oroantral fistula. These are all the advantage of temporary prosthesis. What are the advantage of permanent prosthesis?
Permanent graft will give the contour and support to the orbiters. And
prevents contracture, contour is there. You can reduce that air containing space so that the voice quality, the nasal twang will go. It has got a small cavity through which you can put needles. You can do a brachytherapy if you want. So all these things are all advantages of permanent prosthesis. Okay, so you will not prevent contracture. It looks better. Can have a better orbital presentation. Okay. If the tumor is T4A, then what will you do? After removal, total maxectomy, what will you do?
I will remove disease from the pterygoid, infratemporal fossa, frontal and radiotherapy, sir.
You want to give radiotherapy. Okay, how many racks will you give?
If it is an IMRT, I would give 60 to 70 grays, sir. 2 grays per fraction, 5 days a week. If it is normal radiotherapy, I would give 300 to 3,000 to 4,000 rats, sir. 3,000
to 4,000 rats is the normal telecocal. So if going for an IMRT, you can go up to 7,000 rats. What is sandwich therapy?
Sandwich therapy is pre-operatively we give radiotherapy of 2,000 rats. 2,000 rats, sir. After a 6-week interval, we'll do a surgery, and after again radiotherapy, 6 weeks interval. After surgery, 6 weeks interval, we'll give radiotherapy, post-operative radiotherapy for 2,000 rats.
What are the advantages of pre-operative radiotherapy?
It will reduce the tumor vascularity. It will downstage the tumor, sir, and it will cause margin sterilization.
It makes the inoperable tumor operable. Okay, what are the disadvantages of pre-operative radiotherapy?
The plane of dissection is lost, so disease clearance would not be fully done. And if any graft or flap is to be placed after the surgery, it will not take up well in the pre-operative, if pre-operative radiotherapy is being given.
Even though if it is down stages, for example, an orbital involvement is there, you give up radiotherapy, there is no orbit escapes. Still, you got to do it for the original extent. So it's not going to reduce your tumor this thing. Okay, then it is very difficult to say. Healing is difficult. Then it takes if there is any complication, your surgical time will get prolonged. What are the advantages of post-operative RT?
It will sterilize the bed, any remnant if it is there, then it would be sterilized. I mean, it would be taken care with post-operative radiotherapy.
Then?
And it will reduce the chance of recurrence and recurrent
Residual
lesions.
tumors can be taken care of. Margins can be sterilized. Any inoperable tumor, which is what is left behind, can be dealt. There is no compromise to vascularity. There is no difficult surgery because of preservation of facial planes. So these are all the advantages of post-operative RT. Okay. If patient has got secondaries, develop secondaries after 6 months, what will you do?
I'll do a palliative chemotherapy, sir.
Palliative chemotherapy. Okay, so this is a patient who got a tumor in the lateral nasal wall, extending into the maxillary sinus.
Okay.
It doesn't come up to this level. There is no facial swelling or there is no nasal swelling. What is the other option you have?
Endoscopic excision of the mass, sir.
How will you exist?
I would remove the inferior turbinate and the maxillary ostium would be extended till the floor of the nasal cavity and lamina preparation.
There's a tumor. There are two ways of removing it. One is piecemeal removal, other one is en bloc removal. How will you do the en bloc removal?
Removal of lamina preparation, middle turbinate, inferior
How
turbinate,
endoscopically everything you will remove en masse? Do a modified Denkers, identify the lateral extent of the tumor. You shave it off from the palate and then cut the lamina propria, doing a wide type 3 medial maxillectomy. Okay. What will you do if there is a skull base erosion, tumor extending into the intracranially?
Craniofacial resection, sir.
How will you do anterior craniofacial resection? There's a tumor extending into the ethmoid through the ethmoidal roof, extending intracranially without infiltrating dura. What will you do?
Endoscopic transcribriform excision of the mass.
How will you reconstruct? What are the reconstructing options?
If there is a small defect, I would use fat or fat. For larger defects, I would do.
You got to give a covering.
Pericranial flap.
Pericranial flap. When you put other, when there's a small defect, other lateral nasal wall flap, middle turbinate flap, inferior turbinate flap. These are all for the small defects. Larger defects, you need a pericranial flap. Okay. This is very promising results of an endoscopic excision of the tumor with the present studies. Okay, it might slowly replace the open surgeries for malignant tumors, particularly whenever you try to identify these tumors early, with an advent of diagnostic nasal endoscopies and the imaging techniques available now. Okay. So what is the prognosis of this patient?
For T3 tumors, the prognosis is around 25 to 35%. Sir.
5 years survival rate is about 30-35%. T3 is about 40. T4A is about 25. Okay, 25 to 30. Right. So what is the contraindications to do a maxillectomy?
When the patient is elderly patient, not fit for surgery.
Whenever you say contraindication, it will be tumor contraindication first.
Inoperable tumor, when the tumor extends into the dura or nasopharynx or
2 centimeter or 1 centimeter inside the brain. Dura can be just resected and you can put a flap on top of that. Okay, so if it's brain involvement, then anterior involvement of the anterior wall of frontal sinus from the nasal cavity, then orbital apex infiltration, then pterygoid plates infiltration, extensive nasopharyngeal infiltration, sphenoid sinus infiltration, extending to the lateral skull base, lateral to the mid-pupillary line, then encasement of carotids, unilaterally or bilaterally, or the contraindications, particularly in the tumor. Okay. So, how will you follow up the patient?
So, follow-up is done once in every 3 months for the first year, sir, and once in every 6 months for the next 2 to 3 years, and after that, once every year.
It is for larynx. That's for larynx. What will you do when the patient comes every 3 months?
I will repeat the diagnostic nasal endoscopy, sir, to see if there is any mass, any recurrence, and I will do CT chest to rule out the metastasis.
If you go doing CT chest every 3 months, patient will develop radiation-induced problems in the chest. Then
abdominal examination and USG abdomen.
Okay. Every year, what will you do?
I'll repeat a CT scan or
PET CT. I told you, PET CT is only for secondaries and recurrence follow-up. Do a PET CT every year. If you are not sure of your cancer clearance, every 6 months. Okay.
Okay.
Right. Any other doubts? Any other questions? Anybody?
Sir?
Yes. Satya.
Yes, sir.
Yes, Satya. Tell me.
I think there are a few questions from the audience. One of them had asked, what are the second echelon nodes?
Second echelon nodes, we told it's on the upper deep cervical lymph nodes, particularly level 2A.
Okay. That is, I think, the one question that they've asked. Nothing else, sir. Exhaustive discussion.
They usually will not go to a bigger extent in the nose and paranasal sinus malignancy. Transillumination test, you got to keep the room dark and then apply light. Then you look for transillumination, or like those days they used to take photographs. You keep the patient inside, put a light inside, and put a black towel on both examiner and the patient, completely covering. From inside, you should see whether it is transilluminate or not. Okay, whenever the normal sinuses will transilluminate, this will not transilluminate. Then
I think the questions, those are the questions that we have. Anybody has any other questions? You can unmute yourself and please ask the question. I think you've covered all the aspects of CA maxilla. Honestly, I learned CA maxilla from Grand Rounds in 2020 Grand Rounds. I learned CA maxilla from that. So this is actually a big boon for all the PGs to learn from the best.
Yeah, good evening, sir. Ganapati, sir.
Yeah, Ganpa.
Sir, I joined now only, sir. Just to see you.
Yeah. Very nice.
Finished. So I think 1.5 I've been watching this from beginning, sir. It's a nice
Yes,
thing,
yes.
sir. So what is about that trismus that develops after surgery, sir? Later after surgery. Sir?
That's what the first 6 months they got to give the oral exercises. So that is very important. If you don't do the oral exercises, they will definitely develop trismus. And then the trismus comes, you can do the trismus surgeries, or when the patient has got a good teeth, you can use a cork-like structures, try to increase that width gradually. But since it's a CA maxilla, survival rates are very poor, we will not be aggressive in managing the trismus. Best way to manage trismus is prevent it by doing the exercises from the beginning. From the first month till 6 months, you got to do all the jaw exercises.
Okay, sir, that's one thing, sir. Is there anything like in steps of surgery, sir? So what we are handling the posterior, the level of pterygoid dissection level, is there anything to do with there, sir?
When
What
you
we
do a
sir?
total maxillectomy, this will not occur.
Yes, sir.
Because once you remove only the posterior wall of maxilla, disarticulating from the pterygoid plates, usually it will not occur, except that you cut the medial pterygoid muscle. Okay, but the problem comes only when there is an infiltration inside the pterygopalatine fossa, infratemporal fossa. You dissect and take these muscles out, and that is the case. It is very difficult for you to maintain. That's an accepted, unless it goes for absolute trismus, it's an accepted complication. Mild trismus is an accepted complication in the total maxillectomy.
Thank you, sir. Thank you, sir.
Thank you, Ganapati. I am so happy that you are here. And
Yes.
So I congratulate Ovia for her presentation.
Sir, excuse me, sir. There's
Yes.
one more question from SS. Should PNS tenderness be seen in cases, tested in cases of cheek swelling?
Yes, CNS, it's not called
PNS.
You got to check for tenderness over the swelling, one or the swelling. If there is an increased vascularity, a tumor comes out of the bone, there will be a periosteatis. Whenever there's a periosteatis, it will be tender. And if it breaches periosteum also, there will be a purity arranged and there will be a warmth, and there is mild edema will be there. You should look for pitting edema. So all these things will tell you the tumor has advanced more.
Okay. So thank you so much, sir. Thank you, Ovia Prakash ma'am, for giving out such good answers. And I know it is very difficult to do it in front of everybody, but you did a great job.
Thank you, sir.
Sir.
Thank you. Thank you, Sathya.
Sir, thank you so much, sir. Thank you for giving us more and more knowledge.
Royal Pearl University is taking more interest in spreading the wisdom from the Trichy to the Tamil Nadu to the South India, now and the Middle East. Now it goes to the.
Sir, actually, the seed is sown by you, sir.
No, it's now he is teaching in Uzbekistan.
Yes, yes.
So it spreads throughout the world. So even
he was the first one to give to motivate my father to start this CAT university. So the credit also goes to you also.
Yeah, I am seeing Suman Babu. Hi. So thank you, everyone. Thanks for the.
Thank you so much, sir. Thank you so much for doing this and spreading all the knowledge throughout to all the PGs, especially. Sir, I think there's one more question.
Yes.
No, it's just people are thanking you. The chat box. So thank you so much, sir. You would like to say anything, sir?
No, thank you very much. I should thank you, JANAKIRAM, and then Ziva for conducting this program seamlessly in spite of all these difficulties. I know it's a time for you to take rest. In spite of that, for the sake of PGs, you are all sitting.
Sir, for us, no rest, sir. For us, no rest. So, anything for spreading knowledge.
Yeah, thank you very much.
Sir, we should thank you for telling that, sir, for taking the time out and out of your busy schedule and doing this for PGs, sir. It's a great thing that you're doing. Thank you so much.
Thank you, Satyanarayana. Thank you very much.
Sir, to everybody, we'll intimate the date for the next grand rounds. Sir, what will be the next topic, sir?
Larynx.
Larynx. So we'll be intimating the date for the next grand rounds. It will probably be at end of February or beginning of March. So we'll circulate.
Last week of February, and Janakiraman and me are going to that phonocon. Are you coming?
Sir, yeah, I think I'll be there, sir.
You'll be there. So we won't be available next week.
Yes,
So
sir.
probably we'll do that the last week or first week of March.
Yes, sir. We'll intimate the dates, sir.
Sure. Thank you.
Thank you, everybody. Thank you for taking the time out to come and listen to this. And thank you, sir.